Hi, my name is Liz Gerdeman, and I work for the Brain Injury Alliance of Colorado. I'm very honored to be here today and talk to you guys about brain injury in various settings. And I think you'll learn a lot about the injury itself, how it affects people, and how you might want to accommodate for any clients you might have with brain injury. You might be thinking right now that you don't have any clients with brain injury, or maybe you already do and you know that for a fact, but I think this presentation will hopefully challenge you to acknowledge that more people have brain injuries than most of us realize. I will also talk a little bit about resources at the end, some of which are applicable to Colorado, but also national resources. So first, when we are talking about brain injury, we're talking about anything that's acquired after birth and is not degenerative. So a lot of people, when they hear the word brain injury, they think about TBI, because that's what we hear about in the news, the media. Concussion, for example, is a TBI, but there are other forces and other things that can happen to your brain that can cause damage, obviously, and those are called non-traumatic brain injuries. Both of these are underneath this overarching umbrella of what we call acquired brain injury. So typically when we're talking about brain injury, we remove the T part, the traumatic part, just because the consequences that people face, whether they've had a stroke or a TBI, are similar enough in terms of cognitive and physical challenges. So services and programs for one group are often applicable for the other, and I'll talk more about what that looks like later. I think most people are familiar with traumatic brain injury, assaults, falls, motor vehicle accidents, but some of those non-traumatic brain injuries are internal events. So I mentioned stroke, and that is the overwhelming majority, but we also see things like infection, tumors, lack of oxygen to the brain. I have a little bit more here about mechanism of injury, but individuals may have near drowning experiences or cardiac arrest in which they stop breathing for a little bit and brain cells start to die. Choking, strangulation, those are examples of other things that might cause anoxia. The brain obviously is incredibly fragile. It can slam up into the side of your skull. It can scrape up against bony ridges. And not to get into too much neuroanatomy, but in the majority of the brain, if a brain cell dies, it does not grow back. So unlike skin cells and muscle cells, that if they're damaged, they'll grow back, not typically the case with brain cells. So we often see a loss of functioning with a severe enough injury. Sometimes the brain can compensate, and we see people after stroke learning to walk and talk again, but that doesn't mean that they're going to be 100% back to their normal that they were before. We typically call it a new normal after an injury. So we'll talk a little bit more about that. I realize the graphic with the bat is a little bit much, but what's important to know is that rarely do you ever see just a very specific site of an injury. It's more diffuse. And so, if there are forces making your head go forward, eventually it's going to have to come backwards, and the brain is kind of, sloshing around in there, for lack of a better word, and causing damage in lots of different places. Sometimes the hemispheres can shift, and that can cause all kinds of tearing and damage to neurons and other brain cells. So lots of different things can happen when you get a brain injury. A little bit about youth brains here. It's important to know that the brain does not fully develop until your early to mid-20s. Typically a little later for males. And a lot of people used to think that if a child had an injury at an early age, they were likely to bounce back because they still had room to grow. And what we're learning is that that's not the case. It's actually worse to interrupt that development. And so, if you kind of think about a line graph, and this is the normal development of kids, once a kid has had an injury, they may continue to develop, but not at the same rate as their peers. And so we're trying to kind of change that misconception out there about kids being more resilient. The frontal lobe is the last part of your brain to develop, and that's where things like executive functions live. Also, it's very prone to injury if you think about falls and assaults and motor vehicle accidents, and that's where a lot of damage can happen. So unfortunately, when those executive functions are disrupted or the development of those is disrupted, we see a lot of struggles with adult thinking skills, things like planning, memory, reasoning, judgment, and I'll talk more about that in a little bit, but just kind of keep that in mind. Keep in mind what parts of the brain are responsible for what and how that might lead to an injury and how that might affect somebody. Severity of brain injury is typically classified into mild, moderate, and severe. This is specific to traumatic brain injury. Obviously, there are different scales for things like stroke, but you'll probably hear people say, oh, I had a moderate TBI or I had a mild TBI. And there are a couple different ways that doctors diagnose that. How an individual responds to stimuli after they've been injured, if they're amnesic to the event, and if so, for how long, before, afterwards. But kind of a quick and dirty way to classify severity is if somebody lost consciousness, and if so, for how long. It's also important to note that you don't have to lose consciousness to be diagnosed with a brain injury. That was a common misconception for a long time as well. Concussion and mild TBI are the same thing. So you may hear somebody say, I had a really severe concussion, but note that that is different than a severe TBI, which is loss of consciousness over 24 hours, basically coma. I think it's important to see here, though, that you can be knocked out for half an hour and it's still in that mild category. So these classifications are really about the injury itself, not the long-term ongoing consequences that people experience. We have a number of clients who've had multiple mild brain injuries from things like assaults, and they would 100% not classify their symptoms or deficits as mild. This is really more of a medical terminology and just kind of for your reference. Just putting things in perspective here, brain injury is much more pervasive than I think the average person realizes. We see peaks at different age groups. It can happen to anyone at any time, but there are these times in your life when you're more prone to injury than others. 0 to 4, unfortunately, the main cause of brain injuries at that age is child abuse. So if you think about shaken baby, a lot of people who have toddlers think, oh, it's because they're falling a lot and they're, learning to walk and that kind of stuff. And falls certainly do impact young kids, but it's child abuse as the main cause of brain injuries at that age. 15 to 19-year-olds are experimenting with things like drugs and alcohol and playing high contact sports, but the number one cause of brain injuries at that age is being a driver or a passenger in another young driver's car and getting into a motor vehicle accident. 65 and over, the majority of those are falls. And we're seeing, they're calling it the silver tsunami of that age group in terms of numbers and the number of people that are falling as well, and your likelihood of falling again once you've fallen once. So that is going to be a huge population that needs support in the coming years, as they do right now as well. Males are typically sustaining brain injuries at almost twice the rate of females. And then falls are the leading cause for all age groups in the United States. This number down here at the bottom, the 2.8 million, I just want to caution that the way the CDC currently counts brain injuries, TBIs, is if you've been admitted to a hospital. So if you went to the emergency room and were released, or if you went to urgent care, or if you went to see your primary care physician a couple days later for symptoms after a concussion, you're not being counted in that number. A lot of people don't seek medical treatment at the time of injury, maybe because they're intoxicated at the time, or they're doing something illegal, or they think they're going to be fine. I've had a concussion and I didn't seek medical treatment because I kind of knew what to do and how to take care of myself, but I'm not being counted in that number as an example. So we think it's probably closer to 10 million. We don't have as great of data for some of these other injuries, but a little bit more information here for you to put things in perspective. In Colorado, just as a reference, we have over 500,000 adults who have sustained a brain injury and are living with a disability. We have a research center here at Craig Hospital who randomly called almost 3,000 Coloradans and administered a phone screen with them and asked them about their lifetime history of injuries in general, if any of them involved with their head or neck, and went into a little bit more detail there to learn about potential head injuries. And basically 1 in 4 Coloradans have indicated an injury sometime in their life to their head in which they lost consciousness. So we, as an agency, took that pretty seriously, and we do a lot of education in the community about this, helping people recognize these are your coworkers, these are your neighbors, these are fellow drivers on the road, and we need to know what brain injury is and how it impacts people. So how is brain injury treated? A lot of people ask this question because there's a desire to know, is this individual going to heal? Are they going to get back to normal? How long is it going to take? And it varies significantly. It depends how severe the injury is. It depends what insurance they're on and how much rehab their insurance will pay for. It depends on resilience factors that we don't even fully understand yet. So there are a lot of unknowns. And the first thing I learned when working in this field was if you've seen one brain injury, you've seen one. So it's very individualized to the person and any sort of pre-existing issues they may have had. Typically, we see rehabilitation take place for some of those more moderate to severe injuries. PT, OT, speech language pathologists will do things like cognitive therapy. Independent living skills is a huge focus of rehab, helping people get back to a place where they might be able to live independently if possible, get back to work. Driving, if that's something that they're able to do depending on severity. Medication is something a lot of our clients are taking. There is only one FDA approved drug for brain injury. Everything else is used off-label. So we often have pharmacotherapists talk at our conference every year about here's kind of the status of medication for brain injury, because it really depends if it's an anti-seizure medication or pain medication or antidepressant and what it's being used for, because the brain chemistry is a little bit different for people with brain injury. So if you are working with somebody who needs medication for something and they have history of brain injury, I would highly recommend consulting with a neuropsychiatrist to get more information about that, or a pharmacotherapist. In general, though, people are taking medication for things like pain management, and that includes medical marijuana. Physical symptoms like headache, seizures, attention, and fatigue are often addressed by medication as well. And then mental health, I mentioned that briefly. About 40% or more of our clients are accessing complementary and alternative modalities of treatment. So things like acupuncture, massage, all kinds of different things to help alleviate some of the challenges that they're dealing with from their injury. I want to talk a little bit about mild TBI, because depending on your setting, this is likely the majority of who you're seeing. If you're working with individuals who are more disabled, then it's probably that moderate to severe category. But over 3/4 of brain injuries that occur are in this mild category. So a lot of the brain injuries that are happening are this. Often it's not just one single concussion, it's repeated blows to the head from things like assaults or domestic violence, or, if you think about a motor vehicle accident, there are lots of rotational forces, and, you may be hitting your head on the window and then on the steering wheel, and then in lots of different ways. So it may be that mild injury, but there might be more than one happening at the same time. Sometimes the deficits don't show up right away, or the symptoms don't show up right away. It can take some time for those to kick in. An example that I always give is if you think about a kid who falls on the playground and hits their head and maybe they're knocked out for a little bit, they get sent home right away, right? And they rest and follow the protocol. And then it's not till they're back in school that they're being challenged cognitively, and then they start getting that sensitivity to light and noise, maybe more irritable, maybe more fatigued. And that can be really difficult to connect those symptoms to something that happened 72 hours ago. But that is sometimes the case with concussion. The majority are not associated with loss of consciousness. I kind of touched on this before. A lot of people don't seek medical treatment. It can look like other disabilities. We have a number of clients who've been misdiagnosed with things like bipolar disorder or ADHD. Once you sustain one, you're at an increased risk of sustaining more. And that's because brain injury can impair things like balance and judgment, decision making. I want to comment on imaging because in general, mild TBIs don't show up on CTs or MRIs. And that can be really difficult because sometimes if you do go to seek medical treatment and then you have a scan done and nothing shows up, it feels like you're not being validated in what you experienced. But that's because mild TBI is more of a metabolic dysfunction than it is structural. So I won't, again, get into all the neuroanatomy of that, but long story short, there's like this swell of chemicals and there's an imbalance in sodium and potassium in your brain, and then that causes those symptoms within the first couple of weeks, and then it starts to level out. And so recent consensus from international experts on concussion have said 2 to 4 weeks is when you should start to be fully resolved. And that's good to know because you can have multiple concussions in your lifetime, and if they're not too close together, then you're going to be fine. And so I really want to stress that it's not like you're going to have one concussion and be disabled. But if you have multiple concussions too close together, that's when we start to get nervous. And that's why there are a lot of laws in various states around the country that are requiring athletes to be pulled from play if a concussion is suspected. And so we have that law here in Colorado, and it's really to protect kids, especially from having concussions too close together without their brain having an opportunity to resolve that chemical imbalance and kind of get back to normal. Signs and symptoms are typically categorized into these 4 areas: cognition, physical, emotional, and sleep. These are what are typically impaired by brain injury. So a lot of our clients will report, feeling like they're in a fog, feeling like they're just having difficulty concentrating. Some of the physical symptoms are things like headache. The nausea is typically immediately following an injury, but then will go away after that. But dizziness can sometimes still remain. Balance, like I mentioned before, is impaired. I'll talk a little bit more about the emotional effects of brain injury in a minute. But sleep is also something that's impaired. And again, it's very individualized. Sometimes people sleep more than normal, and sometimes they sleep less. So it just kind of depends on that person. Fatigue, though, is huge for brain injury. And I want to clarify that it's not, I didn't sleep well last night and I'm tired. It's the way that I like to explain it is if you've been at a conference for a week and you've just been absorbing information all week, and by Friday afternoon, you just can't absorb anymore. And I would say that's how a lot of our clients feel on a daily basis. They just need time to process what's going on, what's being said to them, their environment in a different way than we do, and it just really causes mental fatigue. Often we see a lot of loss after brain injury, whether it's functional abilities, neurological changes, life roles. Sometimes people are able to go back to work, but often, there's a break in time, or maybe they can't go back to doing the same kind of work that they were doing before. Or there are those that are going to be disabled and for the rest of their life and cannot, earn income anymore. So that can be really devastating for people. We see a lot of relationships fall apart. Spouses will say things like, this isn't who I married, and that can be really hard. Friends kind of go to the wayside, which can be really hard. Parents and other family members just have a really hard time understanding brain injury and understanding this new person. And I think unlike a broken leg where you may be impaired for a little bit, but eventually you can walk again, the challenges that come with brain injury are personality differences, are emotional. They're not something that most of us are set up to deal with and to accept and to learn to live with. So it can be really hard for people. Isolation becomes huge for people with brain injuries. The risk for homelessness, substance abuse, criminal activity, and mental health issues kind of skyrockets with this population. So in the general population, among everybody, the incidence of brain injury is something around like 8 to 10%. Among the homeless, about 40% of homeless individuals have a lifetime history of brain injury. And among the incarcerated, it's about 60%. We work very closely with several jail and probation sites here in Colorado to educate their staff about brain injury and also refer them to services when they're being released back into the community. So we're really trying to kind of raise the awareness out there that something is happening after brain injury, and maybe it's making people have challenges kind of struggling in society, maintaining employment, maintaining housing, and making good decisions. With respect to mental health, there is a lot of research out there. So if you're interested, feel free to contact me. I'm happy to point you in the direction of various articles or journals or authors. There are a couple bullet points that I've pulled out for you guys here, I think, that are really important. Almost half of adults who have no pre-injury history of mental health issues will develop them after a brain injury. So not once in their life were they ever diagnosed with any sort of mental health issue, and then they have a brain injury, and they do. More often than not, we see depression and anxiety. Hardly ever do we see anything like hallucinations or schizophrenia. It's more of those mood disorders. Suicidal ideation and attempts go up for this population. Families are reporting a lot of challenges, especially with behavior. And what is important to note, this last bullet point, that risk of suicide can persist up to 15 years post-injury. So it's not just the first 6 months of adjusting to the new normal or getting back to life. It's a lifelong struggle. And I think that can be due to a number of things. It could be due to the actual pathophysiology of the injury and where you were injured, and mood regulation potentially being impaired. But it's also due to the fact that you were functioning in a certain way for however long in your life, and then something happened, and now you're a different person, and now your functioning is potentially impaired. So unlike a developmental disability, you are aware of the fact that you're not the same person. Sometimes that self-awareness takes people some time to realize and accept. We see a lot of denial with people with brain injuries initially after their injury, when their functioning is impaired. But once that's kind of kicked in, it can be really hard to live with that. And like I said, depression and anxiety can really jump after that. Things like PTSD are very common for TBI. We see that quite a bit with our military population. Brain injury and substance use or abuse is a complicated relationship. I mentioned before, sometimes people are intoxicated at the time of their injury. If you have a brain injury before the age of 6, I believe you're 3 times more likely to abuse substances later in life. So whether it's for coping skills or coping mechanisms, or just impulsivity in your brain now, there are lots of things that could cause you to abuse substances later in life after a brain injury. And then, like I just mentioned, that damage from the brain injury itself can have, can cause impairments in your ability to make good choices and control, different things, and can sometimes make you more impulsive. We just want to touch on that again. We do see a number of our clients utilizing illegal substances. Some of our clients use medical marijuana, like I mentioned before. And in general, what we've learned from colleagues in the medical research field that substances like that on an already damaged brain are not a good idea. So we typically try to discourage that, whether it's alcohol or even caffeine or marijuana for our clients. Obviously, some of our clients need things like medical marijuana for pain management, so that's different. But we do have a number of individuals who struggle with addiction, and we try to help them with that through the context of brain injury. So what I want to do now is kind of go through this pyramid it's basically our hierarchy of neurocognitive development, and these are the processes that we need to be successful in society, to be productive adults, and we learn them along the way, and it's kind of like math. You have to have basic addition and subtraction before you can move into calculus. And so these are what we develop through life, and I want to kind of go through these and show you how brain injury can impair them, and then how you might want to consider accommodating for those deficits if you're working with somebody who has a brain injury and has impaired attention, for example. So we'll kind of go through these, and I'll give you some examples of what it looks like. A lot of people ask that question: what does it look like? What is somebody with a brain injury, how do they actually present? How is that different from autism or something else? So hopefully this will help clarify that. And then some suggested accommodations. And what a takeaway from this that we really want you guys to know is that you don't have to be a brain injury specialist. You don't have to refer somebody to a brain injury specialist. I think trainings like this and information like this can help you better serve clients with brain injury in your own setting. It's just about how can you consider their deficits and help accommodate for that, and then maybe even promote their own ability to advocate for themselves. Okay, so we'll kind of go through this, and point being is that if some of these fundamental processes are taken out, it can kind of throw off the whole pyramid. So attention. This is something that is often impaired after brain injury. And one thing I do want to say is that not every person with a brain injury will experience all of these all at the same time, but these are just some of those common hallmarks that we see, and hopefully will help you kind of get a better picture of what brain injury looks like. I think we all kind of know what impaired attention looks like in somebody. They can't inhibit themselves. They maybe are kind of squirmy or talking off topic. And so that can be kind of difficult depending on whatever it is you're doing with them, whether it's some sort of mental health situation or, it's a coworker or it's your child. So there are a lot of different things you can do for helping somebody who might have impaired attention. First of all, make sure you have good eye contact. Make sure, they are as focused on you as possible. Work on one thing at a time. We have clients come to us and they have this laundry list of all the different things going on in their life. I need to apply for SSDI and my kitchen sink is broken, and it's just kind of a whole gamut of things. And so try to just focus on one thing at a time until they can move on from that. Keep instructions concise and brief. Make sure that they're involved in the discussion as much as possible. It's not just you talking to them, constantly. If you can control your environment, that is ideal. So I mentioned this a little bit before, but people with brain injuries can sometimes struggle with filtering out their environment. So if you have a quiet space that maybe doesn't have fluorescent lighting, that can be really helpful for people with brain injuries. They need, reduced distractions as much as possible. I'm not going to list all of these. You guys can read them, and if you have any questions, feel free to reach out to me. Processing speed is another skill that is sometimes impaired by brain injury, and so we see it delayed a little bit. Sometimes people are slower to respond to questions. It can kind of feel like they're not paying attention or they're not following instructions. If you think about how this might play out with law enforcement, who might be, barking orders at them and they're not responding immediately, and that can look like maybe they're being non-compliant. So sometimes when we're on the phone with clients and they are, well, this is an impairment that they have, we just kind of have to be as patient as possible and give them time to respond and make sure that they are hearing what we've said. Ask them to rephrase things back to you. Try to speak slowly, but not in that condescending kind of way, because people can easily pick up on that and take offense. Checklists and schedules and routine are really, really helpful for people with brain injury. And some of these accommodations will be repeated throughout. So you'll see things like that. So if you can build a schedule with them, meet with them in the same place on the same day of the week at the same time, that can be really helpful. Written cues is always good. If you are communicating with somebody verbally, also have something written down for them, as a kind of summary, maybe in an email or a text message or however they best communicate. Memory loss is sometimes impaired after brain injury, and it's not that long-term memory. Like I said before, some of our clients are fully aware of their life before their injury or their childhood. It's more about the phone number you gave them 5 minutes ago, or the list of things you asked them to do, or the conversation you just had, or breakfast that they had this morning. That can be really difficult for people with brain injuries to hold on to that information and utilize it. It can come across like it might be an attitude problem because it feels like you're having to repeat yourself a lot, and that can be really frustrating. But I think if you understand this is a deficit of the brain injury, it might give you a different perspective on how to support them. So I mentioned this a little bit before, but if you can provide a written summary of any interactions you have with them for them to review, that can be really helpful. Repeat information and summarize as much as possible. If you know that an individual, hasn't had a good day up until the point that they've seen you, like maybe they didn't sleep well and they had other things going on that day and work or school or whatever it is, and they're exhausted, it might not be a good time to go over new information with them. Maybe try to repeat things that you guys worked on last time and help get that into a place that they can remember long term. Chunking is kind of like how we remember phone numbers, which are in groups of 3 numbers, 3 and 4. And so take something big like that and break it down into smaller pieces for them. It's kind of like if you think about how we as adults have, figured out how to problem solve, reteaching those skills to people is really important, and helping them kind of relearn that information or those processes is basically the goal here. Planners are great. We have a number of clients that use things like smartphones with reminders and alerts and notifications that really help them stay on track and remember what they're supposed to be doing when they're supposed to be doing it. Sensory motor skills are sometimes impaired after brain injury. So I mentioned this a little bit before in terms of light, but noise as well, touch, taste and smell can overwhelm somebody. Some of our clients really get overwhelmed with smells like perfumes or lotions. And so at support groups, for example, we really try to discourage the use of those too much, because it can just be just overwhelming for an individual with a brain injury. And then they can shut down or melt down and not respond well. So it can cause things like irritability. It can cause a lot of different challenges. So if you can control your environment as much as possible, that's ideal. We do trainings like this throughout the community, like I mentioned, and sometimes people have control over their environment and they can really adjust things for their brain injury clients, but other times it's a jail and they have very little control over that. And so how can you, encourage an individual to think about their own triggers and learn to, cope individually and self-manage their frustrations in their environment. And, maybe it's closing their eyes and lying down for a little bit. That can be really helpful. Social pragmatics, moving up the pyramid a little bit, this is basically how we use body language and how we interpret body language. And unfortunately, after brain injury, this is often impaired. So what do they say? I think it's something like 60% of communication is nonverbal. And unfortunately, it's obviously a really important part of our communication style, but sometimes people with brain injuries just don't pick up on that. So, if you're meeting with a client and it's 4:45 and you need to go in at 5 o'clock and they're not aware of the time, they're not going to pick up on any cues you're giving them of looking at your watch or packing up your bag or things like that. So it's really important to acknowledge that sometimes people with brain injuries just have very little insight into that and need specific, direct, structured feedback on their behavior or expectations or things like that in your interactions with them. There's an individual I work with he's very tall and he stands very close to me, and he's not doing it to be inappropriate or intimidating, just has very little insight into the awareness of his personal space or my personal space. And so again, thinking about how some of these situations might play out with authority figures like teachers or law enforcement or other colleagues or fellow students, that can be really difficult to interpret as anything other than inappropriate. So if you're in a situation where you can provide that feedback, that's great. Like, don't assume that they're picking up on your body language or your subtle cues or subtext. Try to be direct and let them know. The individual I was talking about before, sometimes I just have to say, I'm going to take a step back. This is a more appropriate amount of space between us when we're talking, something like that. If you can role play, that can be really helpful, or videotaping interactions is always helpful as well if the individual is open to it. Sometimes they don't know how they're coming off, and so if you have an opportunity to do that, it can be beneficial for the client. Receptive language is the ability to understand what's being said to you. Most of our clients will struggle with abstract language and things like sarcasm. I think we're a very sarcastic society, and we use a lot of metaphor in how we communicate, and unfortunately sometimes that's lost on people with brain injuries. Not to say that they don't have a good sense of humor, it's just if it's an abstract concept like that, sometimes it can be lost. So if you can provide time to make sure the person is processing what's being said, be direct, use more structured, concrete language as much as possible. A lot of this presentation focuses on deficits, but if you can figure out what their strengths are and what previous coping skills they had or what's worked for them before, use those and capitalize on those to the best of your ability. Expressive language is the ability to be understood. So sometimes after a brain injury, people may have language deficits like aphasia or, just all kinds of different things could be going on in their language center, but sometimes it's just as simple as they aren't as articulate as they used to be. We had a client who she had recorded her voicemail message and hadn't listened to it in a while, and at some point listened to it and had no idea how she sounded and was very embarrassed because it was just the grammar wasn't great, or she thought she sounded immature. And so it's situations like that where if you can help them maybe script or practice what they're gonna say or rehearse it, that can be really helpful. Don't be afraid to redirect an individual if they're off topic. If you have a group setting, for example, sometimes that's not always great for people with brain injuries because of their lack of awareness of kind of things that are going on in the situation. But if you do have a group situation, you have somebody in that group with a brain injury, and they may take the group kind of in the wrong direction, or maybe they monopolize the conversation, or maybe they're just doing something that's not appropriate or helpful. Talk to them beforehand and say, sometimes they have a tendency to do this, and let's talk about that. And if you start to do that, I'm going to give you this signal, or I'm going to redirect you. And don't be afraid to do that, to be that person for them. Some of the executive functions we'll go over right now and talk about how those are impaired after brain injury. So initiation, when individuals lack this, it can look like they're being lazy, it can look like they're unmotivated. If you've been around enough teenagers, you sometimes might know what this looks like. Need constant cueing, do your homework, take a shower, things like that. And that's because teenagers, sometimes this part of their brain hasn't fully developed yet. So it's not like they're intentionally being lazy, it's that skill, they haven't developed that skill yet. Sometimes this is similar for people with brain injuries. Initiation may be impaired. There are a lot of different things you can do. Again, I'm not going to read the whole slide, but I think one of the most helpful things you can do is just help them get started. So if it's filling out an application, start the application for them, with them, and then hand it over. Or if we have clients that struggle with initiation and they need a referral needs to be made for them to another service or program, maybe we'll do a conference call with them instead of just giving them a phone number and hoping that they call it, because they probably won't. Mental flexibility is our ability to shift from one idea to the next. And I think we, as adults, think we do this very well. We can, sit at our desk, be working on a project, and then a coworker comes in and can change our, train of thought to something else quickly, and then you can shift it back. And in general, we can do that, or we can multitask pretty well. But people with brain injuries really struggle with this, and they'll just sometimes perseverate on one thing and not be able to think of alternative solutions. Maybe they don't take feedback to that very well because this is the way that it needs to be done. And that can come across kind of like they're being stubborn or argumentative. Again, it's just the deficit of the brain injury. It's not necessarily that this person is trying to be difficult. And that's a huge takeaway that I think I want you guys to have from this training, is that sometimes people with brain injuries are our most challenging population, but it's not because they're all, mean or trying to be difficult. It's just that this is how it plays out, and this is what the deficits look like. So, to the best of your ability, if you can help people prepare for change and practice transitions, that can be really helpful. So if you're going to be working with somebody for, 4 weeks, and then after that point, they're going to be moving on to work with somebody else, preparing for that transition, letting them know each time what to expect when that transition happens, minimizing their anxiety and providing them with reassurance can really help. Help them think through alternative plans. I think we take that for granted. It's something that, if you don't have a brain injury, you can think through, okay, well then what's plan B? What's plan C? And sometimes people with brain injuries can't, they just get stuck on one thing. So help them kind of problem solve that and think about what is a priority and how do I break these down into smaller tasks. And it's, if it's getting a job or going back to school, what are all the things that need to happen between now and then? Reasoning is basically solving problems on the spot and doing that in like a novel way. Again, this is kind of similar to what I was talking about before. People with brain injuries sometimes struggle with learning from that cause and effect and understanding, thinking through the consequences of something. So help them with that. Try to avoid open-ended questions, but help them kind of think through some of those consequences. If you fail your UA, what is that going to mean for you? What does that look like? How do you, how is this going to help you get back to work? How is this going to help you, get your kids back, for example, depending on their situation. And while those are open-ended questions, I think it's helpful to get that conversation started and then help answer those questions for them until they start to learn how to do that themselves. Be concrete as much as possible. And like I said before, identify their strengths. Emotional and behavioral. So we talked a little bit about this before when it comes to depression and anxiety and the mental health fallout of brain injury. But what you'll kind of see on a behavioral day-to-day basis are sometimes people will struggle with regulating their emotions. They may completely overreact to a situation or underreact to a situation. So we see things like maybe laughing at an inappropriate time or crying at an inappropriate time, completely melting down and just it's making it really difficult to work with them. But on the other end of the spectrum, we've also seen people who've had the deficit causes like a completely flat affect, which if you've ever worked with somebody who's had this, it's really interesting. I mean, there's no, engagement from them in their body language or their facial expressions. Generally, when you're talking to somebody, they're smiling and nodding, and people who have a flat affect don't do that. And it can come off poorly if you don't know that they have a brain injury. So to minimize some of these struggles, I think there's a lot of research to show that education about an individual's brain injury can really promote resilience. And so that's something I would highly encourage you to do once you've identified that, somebody has a brain injury. It's really important to help them understand what that means and how does it affect them on a daily basis, and how does it affect their family, and how does it affect their work or school life, and what are they doing about it. So that kind of education about their injury can really be helpful and help them move forward. Avoid only focusing on their deficits, like I've said, although this, again, it feels like this entire presentation is about deficits. Focus on strengths as well. What works for them? What's worked before? Let's try that again. Let's use that. Mindfulness is a great technique that has worked for a lot of our clients, and we actually do mindfulness classes here in our office for some of our clients. And it's really important for probably all of us to be in touch with what's going on and what our triggers are and how to relax ourselves in difficult situations. And so this has been shown to be really helpful and effective for people with brain injuries. Practice positive social interactions as much as you can. So some key concepts from that component, that section of the PowerPoint is, brain injury is often a medical issue at first, and sometimes there are long-term medical consequences of the injury and physical consequences of the injury, but long-term, more often than not, it presents behaviorally. And so people hear brain injury and they think, you have to see a neurologist for anything that's going on with you. When realistically, a lot of our clients are accessing mental health support and adaptive recreation and complementary and alternative medicine. So just keep that in mind, that it's not always, a medical issue that needs medical doctors long term. It's often a behavioral issue. You can create simple strategies and accommodations in your work to support any of the challenging deficits your clients might have. It's not about treating the brain injury or referring them to a specialist. This is just about accommodating their daily struggles. And then before assuming that somebody is willfully disobeying you, consider first if the individual is capable of doing what it is you're asking of them. So call can't versus won't. Are they choosing to not do something, or do they actually need to be retaught that skill? And I think that's really important, especially for kids. I think sometimes we think that kids have, by a certain age, they should know how to do something, and after a brain injury, they may need to relearn that skill. Okay, the last thing I want to talk to you guys about is screening and identification. So we are big advocates for screening for brain injury in any setting. When we're out in the community, whether it's mental health center, domestic violence shelter, homeless shelter, jail, schools, screening for brain injury can really help in a number of different ways, and we'll kind of talk through that. Like I said before, a lot of people don't seek medical treatment, so it's not like you're going to have that medical documentation on hand to know what happened to them, how severe it was, things like that. And brain injury can increase risk for things like homelessness and incarceration, like I mentioned before. understanding if somebody has a brain injury can help you open doors potentially for different support services that they might be eligible for. And then knowing that and can help you better accommodate for them in your setting. So kind of like everything we just went through. Once you know somebody has a brain injury and you know where their impairments or deficits lie, you can accommodate for that in your work and help them learn to accommodate for themselves. There are several components to screening. Training on it is a huge first step, and I'll talk about a couple different tools that are out there. But it's really important to know that anybody can screen. You don't have to have any sort of special background or any sort of license. You can go through like a training or a webinar just to understand a little bit more about it and then implement a screening tool in your setting. Obviously, best practice is medical documentation, but that only indicates if a brain injury happened. It doesn't talk about the long-term consequences and how the individual is today. It's important to establish credible history of brain injury, and I'll talk more about that, but also assess the impact. Things like symptom inventories can really help you better understand the person. And then you can modify your interventions for them based on this information. When you're trying to understand credible history, it's important to know where the injury happened, when, a little bit about the mechanism of injury. Did they seek medical treatment? And it's helpful to kind of think through, are these answers plausible? Are they being consistent? It's basically a structured interview on your part to understand more about the injury. If I were to just say, have you ever had a traumatic brain injury? You'll probably say no, unless you were diagnosed with it. But if I say, tell me about injuries you've had in your lifetime. Did any of them involve your head or neck? Did you ever see stars, get knocked out, lose consciousness? Things like that, terminology like that can help trigger memories of injuries or situations for people that they may not consider, oh yeah, that's a TBI. So if you're talking to somebody, it could help them think about that time that they fell down the stairs and hit their head and think they were probably knocked out for a little bit. Things went black and then they woke up and had headaches for a couple weeks or whatever that looked like. And most people would not say that was a TBI. So screening tools do a really good job of getting to the root of injuries like that and seeing if there are impairments and deficits today because of it. It's really important that they're valid and reliable. They've been researched heavily, that they're sensitive to the population with whom you're working and appropriate to your setting. So obviously you don't, if you're doing an intake with somebody in a mental health setting, for example, you don't want a screening tool to be an hour long, only asking about brain injuries. It needs to be pretty quick and realistic for your use. There are several out there. Brain check survey is typically more geared towards youth. Brain injury screening questionnaire is out of Mount Sinai. Dr. Wayne Gordon, if you contact him, he can give you more information. But the Ohio State University TBI ID is a tool that we use quite a bit, and we've disseminated in Colorado to various community agencies. This is what it looks like. I'll show you both sides. It's just a 2-page document. And it kind of just goes through asking people about their history of injuries and if they lost consciousness, and if so, for how long. It's important to consider trauma-informed questioning in this, because if an individual was in a domestic violence situation for several months, that's obviously hard to talk about. So it doesn't need to be, tell me every time, you were hit in the head or neck, in that situation. It's just kind of 30,000 foot. Did this happen to you? If so, for how long? And that kind of thing. And then on the back is where you record more of that information. And there are a couple different ways to score it. We've modified it so that there are 3 options that would cause a positive screen. So we call them worst, first, and multiple. So if the individual has has had a brain injury in which they lost consciousness for more than 30 minutes, so in that moderate to severe category, then they would screen positive. If they had an individual before, or if they had a brain injury, before the age of 15 with any amount of loss of consciousness, even if it was, 10 minutes, that would screen them positive. And that's because, like I said before, those early injuries can really interrupt development. And before the age of 15 is kind of a red flag for us. And then multiple. So if an individual reports having 3 or more blows to the head in a short amount of time. So that could be domestic violence, that could be, playing football and having multiple concussions, in a game or even over the course of a season. And there was loss of consciousness, then that would also screen them positive. So that's something we look out for as well. So a positive screen basically means this person has a lifetime history of brain injury, and you may want to consider referring them to appropriate resources for that. There are a number of mental health providers, for example, who have experience working with people with brain injuries and can, treat them through the lens of understanding brain injury or use modalities that are more appropriate for people with brain injuries. United States Brain Injury Alliance and Brain Injury Association of America are the two national organizations. Almost every state has like a chapter that's affiliated with either USBIA or BIA of America. We at the Brain Injury Alliance are affiliated with the first. And so there's, each state has entities kind of like us that have support programs and education and conferences and workshops and all kinds of different things. So I would recommend looking into those. The VA created a toolkit specifically for providers who are working with co-occurring mental health issues and brain injury, and they've got some really helpful tools there. Brainline.org is another fantastic website with amazing content, not only for professionals, but also for individuals with brain injury, for kids with brain injury, for family members, caregivers, the whole gamut. They've got really great media on their website. It's produced by WETA. And then cokidswithbraininjury.com is a website here in Colorado that are a couple people in our state created specifically through our Department of Education, and really helpful content on there as well. So especially if you're working with the youth population, there's a whole matrix on that website. You can look up a deficit and then look at accommodations specifically for kids. So I highly recommend those. If you are in Colorado, check us out. We've got all kinds of services for people with brain injuries, support groups and workshops and classes and case management and education support for kids and all kinds of things. We've also got this really cool page on our website that's got little short animated videos about brain injury, so might be helpful to show to somebody, even kids. I think they're applicable. We have 2 of those produced right now, so if you're looking for more information, that's a great spot to go. And that's it. So I'm happy to take any questions. I thank you guys so much for your time. Feel free to contact me directly if you have any follow-up. Thank you.
Hi, everyone. This is Liz. Let me know if you have questions. I'm happy to answer them. Rachel, looks like you're asking me to repeat a question, but I'm not sure which question. I'm not seeing. Oh, from the beginning. So Melissa previously, when we first started this presentation, asked if cerebral palsy is considered a non-traumatic brain injury, and it's kind of hard to answer that question. It depends on the mechanism by which an individual was diagnosed with CP. Sometimes TBI can cause CP if it's under a certain age, but in general, it's the mechanism by which an individual acquires CP is different. And also we will refer to, there's a great cerebral palsy organization in our state, and so we try not to duplicate efforts, and if somebody has CP and they come to us, we typically refer out for that. So if there are any other questions, I'm happy to address them. Thank you guys so much for participating today. I hope it was helpful, and if you have other things you'd like to follow up with, feel free to contact me directly.